Okay, good morning. So this is our last stretch of our gynecologic oncology module. Our topic today is ovarian and fallopian tube neoplasms. This is quite a lengthy topic, and so I would share to you a previously made PDF. I will be uploading this as well in the learning management system, so you may take a look at them. And please don't sell them out. This is for educational purposes. You can just upload it, except for this video, because you can just always view it again here in YouTube in my channel. All right, let's move. So when we talk about the ovary, we'd like to start with the anatomy, because the fallopian tube is very simple to remember. It's just the tubular structure connecting the ovary to the uterus. And so I would like to emphasize on the anatomy of the ovary. Okay, so as you can see here, you are able to appreciate the follicles at its different stages. Okay, there is this big follicle ready to ovulate, and this is the ovulated oocyte from the dominant follicle. As it dies, it becomes the corpus luteum. As it progresses, it becomes the corpus albicans. These are the reserve follicles, and all these we can see at the cortex. Again, the ovarian cortex. Now, the ovary is lined by the germinal epithelium. What's the lining epithelium? Cuboidal epithelium. What else? All right, this is the stroma. This is the medulla. Okay. You will see here in the middle, the blood vessels. This is the hilum. Okay. I hope I made arrows. Yeah, I do. Okay. Cortex, medulla, hilum. Okay, this is the hilum where the blood vessels enter. Okay, so let me share the one I said, PDF that I prepared. Again, this is not for sale, huh? Again, you can download this and share it with others. Okay, so this is the objectives. These are the objectives listed in your paper. And so, of course, we have to identify or compare the characteristics of the cyst, benign ovarian neoplasm, and later on in the part 2, ovarian cancers. Risk factors and protective factors, very important. So in our pretest, I let you differentiate which ones are risk factors, which ones are protective factors. I hope I'll be able to emphasize it here in this lecture, and you are able to retain it better too. All right, there you go. So ovarian cyst can be functional ovarian cyst or ovarian cystic neoplasm. Actually, ovarian masses are mostly asymptomatic. If they become symptomatic, the symptoms are very vague. It can be just pain. It can be dysmenorrhea in cases of endometriosis. It can be intermittent, or it will present with acute severe pain or vomiting, especially when it's an ovarian new growth that is complicated, either due to torsion, rupture, or it's an inflammation brought about by the tubo-ovarian abscess. Now, there might be pressure pains because of stretching of the ovarian capsule. In cases of ascites that comes with the ovarian new growth, patients may present with increasing abdominal girth and early satiety. Hormonal disruption, especially, I keep repeating this, when we started the endometrial hyperplasia, that there are ovarian new growth that releases hormones and thus cause or present as vaginal bleeding. Good example is the granulosa cell tumor. Now, How to diagnose? Of course, we do first pelvic exam. Apart from asking in the history the associated symptoms, you are able to appreciate an adnexal mass through the pelvic exam. You can request for tumor markers, serum beta HCG for germ cell neoplasm, CA125 for carcinoma. Okay, these, however, again, these may be elevated in non-malignant diseases such as leiomyoma, endometriosis, adenomyosis, and salpingitis. Wrong spelling for leiomyoma. That is why I said this is a tumor marker for carcinoma or epithelial carcinoma, because this is a glycoprotein produced by mesothelial cells. Okay. Doc, will CA125 be elevated in cases of sex-cord stromal tumor or germ cell neoplasm? The answer is no. Okay. We have a different tumor markers for them, and these are the ones subsequently mentioned. Alpha fetoprotein for endodermal sinus tumor or embryonal carcinoma. Inhibin for granulosa cell tumor, not estrogen, even when the granulosa cell produces or releases estrogen, the measurable tumor marker is inhibin. Lactate dehydrogenase for dysgerminoma, CAA and CA19-9 for specific for mucinous ovarian carcinoma, similar to the lining epithelium of the GI tract. On ultrasound, this is considered to be the first line tool to evaluate pelvic masses. We will be able to appreciate color flow in color flow Doppler among malignant ovarian new growth or those with malignant potential. And of course, you will be able to appreciate also the blood flow or loss of the blood flow if we are suspecting torsion. Okay, what do we do? If it's only a functional cyst, then we'll not have to do anything. We can just observe because it usually regresses spontaneously. Okay, in postmenopausal women, if it's thin-walled, unilocular, diameter is small, no cyst enlargement, and normal CA125 level, no need to worry. Surgical management can be either cystectomy, you just remove the cyst, you leave the ovaries behind, or you remove the whole ovary, or you do complete surgical staging for malignancy. Complete surgical staging means you do not just remove the ovary, you remove the uterus, you remove the cervix, uterus, fallopian tube, ovary, nodes, and the pelvic fluid or for cytology. Okay, factors to consider, of course, when choosing what surgery to do, you have to consider the size of the mass, okay? Especially in very big ovarian masses, and there is no more normal ovarian tissue seen. Others would opt for oophorectomy. However, the guideline now is we always try, especially for reproductive age women, we always try to just remove the cystectomy as much as we can, because no matter how small, we still hope that that small remaining normal ovarian tissue will function. Patient's age and intraoperative findings. Route, we can either do laparoscopy or open laparotomy. Usually for ovarian new growth, since they come to us very huge, and especially if malignant, we advise for midline vertical incision for us to have a better operative space. Now, functional ovarian cyst, as I said, depending on the location, okay? Where is the ovarian follicle located? It's in the cortex. So the ovarian cysts originate from ovarian follicles, and these are created during menstruation and ovulation. Associated factors, because of hormone influence. As you can see, progestin, tamoxifen. We keep repeating tamoxifen in the endometrial hyperplasia and carcinoma, greater BMI, and smoking. Follicular cysts are frequently multiple and sizes vary up to 15 centimeters. Physiologic cysts, usually among young and menstruating women, these are not neoplastic and dependent on gonadotropins for growth. These are usually persistent follicles, and they are incidental finding in ultrasound because women are usually asymptomatic, although some present with menstrual irregularity, but that's not very common. Usually it's incidental finding on ultrasound. Grossly, it looks translucent, thin-walled, and are filled with watery, clear to straw-colored fluid. Now, on microscopy, we appreciate a a thin-walled cyst. Okay, so here, okay, so this is usually how we get the cystectomy. Okay, follicle cyst, check, remove, and then this is the section under the microscope. Now, on ultrasound, it's anechoic, thin-walled, and usually resolves on its own. Follicular cyst, 4 to 8 weeks. If more than 10 weeks or enlarges, you have to rule out a neoplasia. So you have to monitor for you to be reassured na this is just a follicle cyst. It's just a physiologic cyst. We have to make sure that it regresses on its own. Although you can go for an OCP for 4 to 6 weeks, especially if there is fast growth. Okay, you are suspicious of a malignancy. You look at the patient's age, family history, other symptoms, CA125 level for postmenopausal women, because I said CA125 level can be elevated among reproductive age women. There is a low resistance in color Doppler. Okay, if we are considering malignancy, so this is something that we should look into if we are suspicious of malignancy. Now, it can, again, the size, if you want to surgically remove, you should have a cutoff of more than 10 cms. As I said earlier, it can be as large as 15 cms, but usually I very seldom meet a follicular cyst more than 10 cm. If it's really huge, then that's the time we do cystectomy or surgical removal. Okay, corpus luteum cyst can also be another ovarian cyst. This is more important clinically, at least 3 cms in size. This is usually associated with prolonged progesterone exposure, and menstrual pattern can either be delayed, normal, or absent. So asymptomatic masses, catastrophic and intraperitoneal bleeding associated with rupture. After ovulation, some women really come because of severe abdominal pain, and on ultrasound, it's a hemorrhagic corpus luteum cyst. Later on, I will show to you the presentation of it in the imaging, because it has a very close differential to ectopic gestation. Here, Halban's triad, because of course it presents with a ring of fire, and they have the same symptoms of delayed menses, or it can present with spotting. There is pain in the pelvic area or the adnexal area, because a hemorrhagic corpus luteum cyst is painful. It's dull, unilateral in the lower abdomen, okay, and moderately tender on pelvic exam. So again, delayed menses, pain, and you will be able to appreciate a small tender adnexal mass. This is the Halban's trial. So how to differentiate with ectopic gestation? Of course, your simple pregnancy test will do, okay? Okay. Hemorrhagic cyst with lacy reticular internal echoes. Only peripheral flow. This is what I said, the ring of fire, consistent with hemorrhagic corpus luteum. Where do we remember another ring of fire? Ectopic gestation. So that's why I said the very close differential is ectopic gestation for a hemorrhagic corpus luteum cyst. Now again, to differentiate, do a pregnancy test. Very simple. Okay, another close differential can be adnexal torsion. Management, if there is a corpus luteum, then hemorrhagic corpus luteum will have to observe. Usually it resolves in 24-48 hours. You can just give pain meds, observe if there is no relief of the symptom, then or if there is instability of the patient, of course we have to go in. However, you can just be conservative with your management because most of them will resolve after 24 to 48 hours. If she really has severe symptoms, we can suppress ovulation on the next cycle to avoid recurrent hemorrhages. THECA lutein cysts, these are uncommon type of follicular cysts characterized by luteinization and hypertrophy of THECA internal layer. These are bilateral, multiple, smooth-walled cysts and ranges from 1 to 10 cm. Remember the hyperreaction luteinalis or the huge bilateral ovarian new growth THECA lutein cyst in elevated LH or beta HCG level in our first topic, the GTD. Okay, what GTD or molar pregnancy? The complete molar pregnancy, complete H-mol. Or there is also high beta HCG level among multifetal gestation in large placenta or in OHSS in ART, especially when we try to induce the ovulation, okay, and all those procedures in ART. This is typically regress, okay, spontaneously or persist a little bit more after normalization of HCG. That's why in GTD, if there are THECA lutein cysts present, we don't have to do cystectomy with these cysts because once the beta HCG goes down, this THECA lutein cyst will regress. This is also associated with luteuma of pregnancy, whereby there is virilization of female fetus. So this is the microscopic finding of the THECA lutein cyst. So as I said, conservative, spontaneous resolution. If discovered incidentally, be careful because this may bleed. Okay, as I said, ring of fire, unilocular, COC, no evidence that actually there's no evidence to give the COC. Unlike functional cyst, others give OCPs for the 4 to 6 months to regulate the GnRH stimulation, gonadotropin release, influence in the ovaries. For here, although the purpose of giving COC is to prevent possibility of recurrence, especially when patient was really in pain and she does not want to experience the same. So will prevent ovulation in the next cycle. Again, surgery for masses more than 10 cm. Okay, 10 cm. Ovarian cysts. All right, here you go. These are characteristics of simple cyst, hemorrhagic cyst. Other ovarian masses we'll discuss shortly. Okay. Ovarian neoplasm. If ovarian cysts are purely benign, ovarian neoplasm can either be benign or malignant. Again, anatomy. Where does this come from? Does this come from the surface epithelial cells? Does this come from the germ cell? Or does this come from the stroma? or the sex cord stroma, or it can be a metastasis from other sites. So basically, for discussion, we'll give you the surface epithelial cell neoplasm, germ cell neoplasm, sex cord stromal neoplasm. Again, the most common, surface epithelial, followed by germ cell, followed by sex cord stromal in overall frequency. Consistently in malignant tumors, still what's number one is the surface epithelial neoplasm. Okay, these are the examples these are the examples of surface epithelial neoplasm. As you can see, these are lining epithelium. Very easy to remember. While the germ cell, germ cell, teratoma, dysgerminoma, endodermal sinus tumor, choriocarcinoma. While the sex cord can be fibroma, granulosa cell, Sertoli Leydig cell, Tecoma. Okay. All right. There are characteristics of the tumor, either the M or the B, malignant characteristics, and the benign characteristics. Okay, so it's 1 to 5, and then we are able to differentiate them. This was what I mentioned, the color flow. Very strong blood flow for malignant characteristics, while no blood color in B5. Benign cystic teratoma, dermoid cyst, or mature teratoma origin, germ cell. Okay, most common, 90%. Okay. Elements from the 3 germ layers are appreciated. Dermoid is a descriptive term that emphasizes the preponderance of ectodermal tissues with some mesodermal and rare endodermal derivatives. Unfortunately, this may contain malignant components, especially among older population. And where do we see the malignant transformation? It's usually at the squamous area. So we have to look at if there is no squamous carcinoma at where the squamous area is. It's bilateral in 10 to 15%. It's really quite heavy. Okay, it can be both cystic with solid components, and it has doughy consistency. Usually unilocular, but I'm not saying it cannot be multilocular. Walls are smooth, shiny with opaque white color. When opened, since it comes from the 3 dermal layers, so of course we can get representative from each dermal layers. But if it's a majority of the epidermis, so we call it microscopically, we appreciate more skin, okay, all from epidermal layer. So we call it, the diagnosis is dermoid cyst. But you can just call it benign cystic teratoma, mature teratoma. The sebaceous material is a thick fluid at body temperature but solidifies when it goes in room air. So there are really sebaceous material inside. Teeth, bone, cartilage, hair, everything. It's amazing that you will see this in the ovary. Okay. You see in this section, the microscopic section of a benign cystic teratoma, the ciliated pseudostratified columnar epithelium. Supposedly, it should not be in the ovaries, of course. Even hair follicles, it should not be there. Adipose tissue, here. The stratified squamous epithelium. That's why I said we have to look into these parts because carcinoma can arise from here. Sebaceous glands, cartilage. So all are mature. That's why mature cystic teratoma. Mature. Okay. Well, others will discover this incidentally on ultrasound. However, because this is heavy, pelvic pressure is usually also the symptom. The most common complication is torsion. In fact, I just had one surgery because this patient had been very anxious of having her bilateral dermoid cyst removed. However, just 2-3 days after that, she had severe abdominal pain, and truly when we opened the right ovary was twisted 4 times and the left ovary once, or complications other than torsion include rupture. We have to be careful because if there is rupture of dermoid cyst because of the sebaceous materials inside the cyst, there can be severe chemical granulomatosis, peritonitis. The abdomen will abdominal pain really severe, infection, hemorrhage, and as I said, malignant degeneration. Again, where in the squamous most commonly. Well, we can also name it struma ovary when the majority is or no, not majority. When under microscope, what we see are thyroid tissues. Okay, usually also patient will have elevated hormone levels because although very few research show that these are functional, these cells are functional. I also met a patient that her thyroid hormone, she has hyperthyroidism, and upon removal of the ovarian new growth, it resolved. And truly, after looking at it in the microscope, those were thyroid tissues. Okay, carcinoid syndrome, GI or respiratory epithelium, autoimmune hemolytic anemia. These are associated medical conditions. Okay, cystectomy. Usually these are reproductive age, so we really just do cystectomy as much as possible. Conservative, if less than 10 cm among pregnant patients, we just have to make sure that there is no ongoing complication. Okay, we have also to look into the tubercle of Rokitansky. It's that, what's that structure here? Okay, it's a tubercle of Rokitansky. It's like on ultrasound, it's the hyper echoic portion of the ultrasound. It's a solid area, but actually, it's not really a sign of malignancy. It's the tubercle of Rokitansky that we should look at also under the microscope. Next, after teratoma is endometrioma. It's asymptomatic also for some, but if there are symptoms, because these are ectopic endometrial glands and stroma, patients complain of pelvic pain, dyspareunia, and infertility. Acute symptoms cause 10% of operations, especially when there is rupture and perforation, okay, due to cyclic hemorrhage. Usually, patients complain of severe pain at the start or during menstruation, okay? It can be very severe. The pain can be very severe. BPE, ovaries are often tender and immobile because of adhesions. Densely adherent to surrounding structures, so unlike the dermoid cyst, chances of torsion not much, but rupture, yes. Okay, it can even adhere to the pelvic side walls, to other structures, the bowel, the bladder. Okay, again, microscopically, endometrial glands, endometrial stroma, and large phagocytic cells containing hemosiderin. Yes, you will appreciate this under the microscope. And you will be surprised that the ovary can contain a lot of things. Thick-walled, homogeneous echo pattern and is somewhat echolucent in sonography. Here you go. This is ultrasound. And this is the endometrioma or the endometriotic cyst, okay, on laparoscopy. All right, there, microscopic. Supposedly, we do not see endometrial glands and stroma in the ovary. So if we see, then that's endometrioma. Look at the patient's age, future reproductive plans, and severity of symptoms. Do we always remove it right away, doc? Although it says here medical therapy is rarely successful, medical therapy can work among not so large endometrioma. Okay, we have already medications available in the market, and I don't do surgery right and left for endometrioma. Why? Again, because of complications. As I said, there are severe adhesions associated with endometrioma. We'll only intervene if it's really big or it's complicated, undergoing rupture. Next, fibroma, most common benign neoplasm of the ovary. Malignant potential is low, 5% of benign ovarian neoplasm and 20% of all solid tumors of the ovary. Slow growing, associated with ascites, 9% unilateral, often presents in postmenopausal women, and arises from undifferentiated fibrous trauma, again, stromal cells, origin stromal cells. Now, bilateral ovarian fibromas are commonly found in women with rare genetic transmitted basal cell nevus syndrome. Presents with pressure and abdominal enlargement. Smaller tumors are asymptomatic because these tumors do not elaborate hormones. These are easily palpable, appear to be softer than a solid ovarian tumor because of the edema or occasional cystic degeneration. Okay, remember this, Meigs syndrome. It's the ovarian fibroma that presents with ascites and hydrothorax. Once the ovarian fibroma is removed, the ascites and the hydrothorax resolves. Here, this is fibroma. Okay, well, surgery, removal of the fibroma, but among postmenopausal women, we do total abdominal hysterectomy with bilateral salpingo-oophorectomy. Largely because of the age, the risk of the age as well. How about the transitional cell tumor? Still epithelial, it's transitional. We call it the Brenner tumor, result from metaplasia of coelomic epithelium into uroepithelium. Generally asymptomatic. This is associated with concurrent serous cystic neoplasia, serous or mucinous cyst adenoma. Postmenopausal bleeding can also occur, and so endometrial hyperplasia in 10 to 16% of cases. Two principal components of the Brenner tumor, solid masses or nests of epithelial cells surrounding a fibrostroma, inner layer of endocervical type of mucinous cells, and an outer layer of stratified cells. Okay. Transitional cells. This is the mucinous area. Remove, surgery. Okay, adenofibroma or the cyst adenofibromas. These are another benign tumors consisting of fibrous and epithelial components. Epithelial element is most commonly serous. Okay, again, epithelial element is most commonly serous, but may be mucinous, endometrioid, or clear cell. There is preponderance of connective tissue. It can be gray or white in color. Small precursor of adenofibroma are identified in many normal ovaries. True cystic gland spaces lined by cuboidal cells. Again, ovarian new growth in postmenopausal women, tabso. But among reproductive age women, as much as possible, no matter how large the mass, we try to save the ovary. So cystectomy. Even with patients with torsion, you just have to release the torsion, and then the blood flow will resume, and then just do cystectomy. That's how I did with my patient. Oh, speaking of, it's uncommon but an important cause of acute abdominal and pelvic pain. 3% of all acute abdomens present to the emergency department because of torsion. Well, pregnancy can be a predisposing condition, and the most common cause of ovarian enlargement by 8 to 12 centimeters benign mass of the ovary. Well, if early diagnosis of adnexal torsion, operative management in 75% of cases, untwisting, and then cystectomy, as I said. However, with severe vascular compromise, especially when there is already necrosis for a long-standing adnexal torsion, then we might have to remove also the fallopian tube. However, chances of fertility is decreased. That is why it's very important that when you are suspecting an ovarian new growth in complication, especially dermoid cyst, as I said, it's heavy, and so it's common to be twisted. So you will really suspect if a patient with ovarian new growth complains of severe acute lower abdominal and pelvic pain. Okay, so it was long, huh? I said this is a very long topic, and so part 2 is now on. So I hope you were able to catch up. Those are very important details on ovarian cysts and benign neoplasms. Benign, we are still at the benign. Now it's on the cancers, okay, the malignancy part. Okay, are you ready? These are the risk factors. So I hope you were able to answer in the pre-test the protective and the risk factors. So you just have to match whether it's protective or it's a risk factor. It's a protective factor or a risk factor. Doc, why is tubal ligation part of the protective factor? Later on, the last topic, the last 2 slides, because in the book, fallopian tube carcinoma is also very short, you will appreciate why tubal ligation is a protective factor. Okay? All right. We move. So familiar with this already? Again, I just have to emphasize again the source. Okay. Now, if earlier in the benign, it's adenoma or cyst adenoma, now, again, malignancy, carcinoma. Among the epithelial ovarian tumor, even in the benign or in the malignant, it's always serous. Okay, serous is on top of the list. Okay, what are the things to remember when we talk about serous carcinoma? Most common, primarily from the fallopian tube. That's why I said in the very first slide in the malignancy that tubal removal of the tubes is protective because the chance of having a primary source from the fallopian tube is removed. Now, if we talk about things to remember, serous carcinoma, samoma bodies. Okay, serous samoma. Well, since I'm a Bisaya, I usually remember this as ayaw kog samoka because I'm serious. Samoma, serious. Okay, you see, it's very easy to remember. It mimics the intestinal cells as I mentioned earlier. That's why it's elevated CEA. Endometrioid, well, this is most commonly seen in endometrioma. So, diba, endometrioma is benign ovarian neoplasm. However, chances of malignancy will be there, and the most common malignancy seen is the endometrioid. Although, again, clear cell can be there. When we talk about clear cell, hobnail, okay? And the ovary, unlike cervix, vulva, is usually not related to DES exposure. And unfortunately, clear cell histology is highly aggressive. BRENNER, as I said, epithelium of the bladder, yolk sac tumor, or the endodermal sinus tumor secretes alpha-fetoprotein. So you'll just have to remember yolk sac AFP, endodermal sinus tumor, AFP. Another one I will remember for yolk sac that I failed to write here are the Schiller-Duval bodies. Again, I'm wrapped with a sac because I'm shilling. So that's how I remember Schiller-Duval bodies, yolk sac. Granulosa cell tumor, call Exner bodies, also in histology under the microscope. And tumor marker is inhibin A. Granulosa cell, call granny. So that's how you remember the pathognomonic histologic sign. Call Exner bodies, call granny. Yolk sac, Schiller-Duval. I'm shilling, so put me in a sac. Okay. Serous Samoma bodies. Okay. And lastly, for this germinoma, the tumor marker I keep repeating is LDH. All right. You know, this is very important. We're even up to boards. Okay, in presentation, you have to look into bilaterality. So look, the percentages, okay. So it is specified in this table, the benign, the malignant counterpart, benign, malignant, benign, no, the malignant and the benign. Now, benign cystic teratoma is benign, but however, you have to look at the squamous component because squamous carcinoma can arise from there. The immature teratoma is the malignant counterpart. This germinoma is malignant. So look into the chances of bilaterality. While for sex-curved stromal tumors, these are rarely bilateral. Okay, I think I have mentioned this already. Okay, the B and the M rules. Of course, when we are dealing with benign, it's more here. If malignant, here. Okay, as I said again, ovarian symptoms are vague. General, usually incidental. If it presents with symptoms, there is increasing abdominal girth, bloating, urinary urgency, pelvic pain. Now, staging is based on the result of operative exploration. So upon surgery, if we already will be able to see omental caking, so that's already 3C. So it's automatic na, you know, okay? So what to do? So we will be able to anticipate CT scan of the abdomen. So sites are considered inoperable if there is retroperitoneal suprarenal lymph node enlargement, mesenteric disease, portahepatis disease, bilateral parenchyma liver metastasis. PET scan, colonoscopy, because there are cases of genetic familial mutations, as I said, colon carcinoma. So we have to make sure that this is not a metastatic malignancy. So determine the CEA. And of course, the CA125 level is not actually a screening tumor marker. No, it's actually necessary for monitoring response to treatment. We get a baseline, and then when monitoring response to treatment, we will measure it again. Disease spread, infiltration of peritoneal surfaces of parietal and intestinal areas right under surface of diaphragm. It can be lymphatic, parayortic. Prognosis, mainly stage. What cell type? Again, aggressive, clear cell. Serous, most common worse prognosis if poorly differentiated. Mucinous and endometrioid, better prognosis. Transitional cell carcinoma is a key, most sensitive tumor. Oh, I said already, clear cell, worse prognosis and is aggressive. And of course, prognosis relies on the remaining or the residual tumor after resection. That is why the goal of surgery is to remove everything that can be possibly removed. So in your book, you can look at this. That's why I said, if you already will appreciate omental caking, Microscopic peritoneal metastasis, more than 2 cm in greatest dimension. Oh, that's automatic, Tracy. You don't have to measure the ovary, the etc. You know, already opening. Tracy. Okay. As I said, primary treatment of ovarian epithelial carcinoma is removal of resectable gross disease. As much as you can, try to debulk. Okay. Yes. Our goal is to achieve optimal cytoreduction of less than 1 cm residual disease, again, because prognosis relies on the residual disease. And so it's very important that we are able to remove as much tumor as possible. One exception is the required removal of the uterus and opposite ovary occurs in case of well-differentiated ovarian tumors confined to one ovary. Okay, so especially among, okay, here, I think this is that. Okay, I think this is very important. Young woman of childbearing years with a strong desire to preserve reproductive function. You may not, again, exception to the required removal of the uterus and opposite ovary. So example, is the right ovary that is involved. Ideally, when we say complete surgical staging, we remove the uterus, both the fallopian tubes, both the ovaries, the lymph nodes, peritoneal fluid, omentum, right? But among young women of childbearing age, we are also considering the grade, negative PFC, and omental biopsy specimen negative. Then we can leave the rest of the anatomy behind. We can leave out the rest of the structures behind. Just remove the affected side, the unilateral, or we call it the unilateral salpingo oophorectomy. And then still, of course, monitor afterwards. So you have removed already the nodes, the omentum, and the peritoneal fluid because you already were able to identify all these. So there you go. All right, this is a case of LL complaining of pain. She had amenorrhea, okay, but heavy menstruation. Advised to do TVS, failed. Unremarkable medical history. There is, because she came in due to abdominal pain, pain score 8/10. Truly, there is tenderness. And there is a palpable red adnexal mass. And truly, there are red to brown discharge. Now, on TVS, endometrium is thick with an ovarian new growth on the right with solid areas demonstrating moderate color on color flow mapping within the wall. There is no right normal ovarian tissue seen. So just upon seeing this, plus CA125, is this normal or abnormal? Is 15.5 abnormal or abnormal? So the range is less than 35. So CA125 is normal. So later on, you will realize that CA125 again in these cases will have no role. Especially looking at the TVS, it looks malignant already. So you should again have already an inkling. What am I dealing with? Definitely, this is an ovarian new growth. Now, are we dealing with a possible benign or a possible malignant? So looking at the B and the M features, you already have a suspicion. Now look at the presentation of symptoms. Okay, presentation. Okay, ovarian new growth, right? Probably twisted versus ruptured because she comes in with pain. I am considering a possible malignancy, and because she comes in with irregular bleeding or AUB, so I'm considering a sex cord stromal tumor, granulosa cell tumor. And of course, don't forget AUB M1, probably secondary to GCP. Because again, 1.7 thickness of the endometrial is thick, so I hope you don't forget yet AUB. Okay, that's the support of my impression. Of course, don't forget the gravidity. It's very important, newly gravid. Okay. Why is the CA125 level normal? Because as I said, this is a sex-cord stromal tumor. What's the tumor marker for granulosa cell? Inhibin, not CA125. Okay, there. Okay, management, emergency surgery, definitely, because this is an ONG that is complicated. We do explore laparotomy, and because because we are suspecting malignancy and reproductive age woman, okay, look at the age again, future reproductive plans. We did fertility sparing surgery, USO, unilateral salpingo-oophorectomy, since it's the right, so we remove the right ovary and fallopian tube, and complete surgical staging, PFC, omentectomy, and pelvic lymph node dissection. I think I failed to write that, of course, with frozen section, because we cannot just assume that this is GCT without histologic support. Okay, will be questioned. So a frozen section should be done to ensure that our clinical impression is supported by the pathologic microscopic findings. All right, so that's how you apply ovarian malignancy. So I hope you remember again, three very important: epithelial, sex-cord stromal tumor, and germ cell tumor. Germ cell usually in the young. Epithelial cells, if in the young, is usually benign. The adenoma or cyst adenoma. If it among the postmenopausal, then we are likely dealing with a malignancy. Germ cell. The sex cord is very obvious because since it releases hormones, it presents with issues with bleeding. Now, fallopian tube, okay? Very short. The high-grade serous carcinoma is the most common histologic type. So same with the ovaries serous, okay? There is an inherited mutation of the BRCA1 and BRCA2 genes, and these are the primary risk factors of fallopian tube cancer. This is associated with inherited ovarian and breast cancer, diba? I said already earlier, gene mutation, familial in pattern of spread. And so risk reduction bilateral salpingo-oophorectomy are done among women who have completed the goal of their family, the plans of family and birth number. So we remove both tubes and ovaries. So risk reduction surgery, that's why it says RRBSO. So that's why in one of the protective factors, it says there, the removal of the tubes is protective for ovarian carcinoma. So we mentioned a triad earlier, the Halban's triad for hemorrhagic corpus luteum cyst. Another triad in fallopian tube cancer is the LUTEUM triad. This involves the colicky pain, adnexal mass, and the serosanguinous discharge in fallopian tube carcinoma. Why is there colicky pain? Because the usual location of serous cell carcinoma is in the fimbriated end or in the fimbria. Diba? It's a trumpet-like. So if it's obstructed, as the fallopian tube tries to contract, there is an obstruction here, and so it produces colicky pain. And because the fluids cannot be released on the other side because of the obstruction, it presents as a serosanguinous discharge. Of course, we will be able to palpate adnexal mass. Precursor lesion, serous tubal intraepithelial. Okay, cancer. Okay, this is similar to the CIN3, endometrial carcinoma in situ. So as long as there is no break in the basement membrane, it remains to be a precursor lesion. Risk factors, similar with ovarian carcinoma. Infertility, low parity, early menarche, late menopause, exposure of what's this? Hormones, of course, becomes a risk factor. Protective is OCP use because there is no injury of ovulation, no rupture of the ovary, multiparity because the more frequent you get pregnant, so the lesser ovulation that occurs. Breastfeeding also. And again, tubal ligation. Management, complete removal. During surgery, improve survival. Same with ovarian carcinoma. Um, the better prognosis is when there is complete removal of the tumor. Stage of the disease determines also prognosis, is the most important determinant of prognosis. Although it's familial and not a very good use, if it's present in the family, BRCA mutation carriers has a favorable prognosis. All right, that's the end. This is the longest lecture we had so far, right? So I hope you were able to absorb. Okay, thank you very much. Good luck.